Well, I'm really happy to introduce Shelby Atkinson with us this morning. Shelby's the Genomics and Newborn Screening Research Coordinator at Michigan State. So Shelby obtained her master's in public health at Michigan State and then immediately took on this job. She had been working during her academic work at Michigan State under Nigel Paneth. And in the course of that work was performing analyses using blood spots, and part of her job was collecting or coordinating some of that research activity. And so she was a natural fit for this position when it opened up. And she's been there about 5 years or so. And anyway, we're looking forward to hearing from Shelby about the newborn screening program and the availability and use of blood spots. So take it away, Shelby.
Thank you so much. I did practice my screen share. We're a mostly Teams operation at MDHHS, so hopefully it goes as smoothly as it did the first time. Okay. So thanks so much for the introduction. Again, my name's Shelby. I am the Genomics and Newborn Screening Research Coordinator here at MDHHS. And in a majority of my role, I oversee the Michigan BioTrust for Health program, which is a program that oversees the research use of blood spots that are left over after newborn screening is done. So just to go over kind of a few objectives for my talk today, while we're together, I'm hoping to provide you guys with some details about our BioTrust program and why there are blood spots left over after screening. We're going to talk a little bit about why there's such a unique resource for medical and public health research projects. We'll go over the availability of these projects or of these blood spots for research, and then outline some of our MDHHS policies regarding acceptable uses, and then actually spend just a few minutes describing the process of how researchers can access these specimens for their own research projects. So it's really hard to start this conversation without starting with why we have these specimens in the first place. So I just wanted to take a few minutes and provide you all with an overview of newborn screening, specifically newborn screening here in Michigan. So as many of you are probably aware, newborn screening is considered kind of one of the biggest public health wins that we've had in quite a long time. Here in our state, newborn screening is mandated by Michigan law through the Public Health Code. It's actually mandated that the provider who's caring for the infant shortly after birth collect the specimen for the purpose of newborn screening. This program is operated here at MDHHS under a joint partnership between our Bureau of Laboratories and our Bureau of Epidemiology and Population Health. So our Bureau of Laboratories is responsible for testing the specimens, and the Bureau of Epidemiology and Population Health is responsible for what we call our newborn screening follow-up system. Newborn screening is not funded by tax dollars. It's actually funded by the purchase of the newborn screening card. So I included the cost here just to kind of show what that looks like specifically for families. For the most part, for our hospital births, these are billed out to insurance through like general coding for delivery at a hospital. So most families in Michigan do not see the burden of this cost. It's $144.50 for a first sample. And then if families have to have a repeat sample, that does cost $131.05. This price is determined based on the cost of the newborn screening card itself, as well as the need to acquire different items for the assays that are being run, and does change based on the conditions that are being screened, as well as the Detroit Consumer Index increases per year. In Michigan, there are 3 components to our newborn screening. So we're going to focus mostly on our blood spot screening since we're talking about blood spots. But there are 2 other what we call point of care screens here in Michigan. So all babies receive blood spot screening. They also receive a pulse oximetry screen in the hospital setting. That is a pulse ox that's put on the baby's foot to measure oxygen traveling throughout the body to detect critical congenital heart disease and other heart-related issues. And then there's also a hearing screen that babies receive in the hospital or by a midwife in a home birth setting. For the pulse oximetry screen and hearing screen, families receive their results right away. For blood spot screening, blood spots are sent to the MDHHS lab for testing. This is just an overview of our Michigan blood spot screening and follow-up system. So this is specific to the blood spot portion of the screen. We start on the left with our hospitals and midwives with that little foot there. That's kind of the start of this diagram. Hospitals and midwives are responsible for collecting specimens from all babies born across the state. Those specimens are submitted to our MDHHS newborn screening laboratory. For normal screens or screens where the baby does not screen positive for any of the conditions that are on the panel, we've been trying to get away from normal or abnormal because, of course, they're only normal for the conditions in which are currently included on the screen. But if they do not have any of the conditions on the screen, a report is sent back to the hospital. It's also uploaded into the Michigan Care Immunization Registry, or MICR, which is accessible by pediatricians. And those results are available at the pediatrician's offices about 1 week after the child is born. When we have an abnormal screen, that triggers what we call our MDHHS newborn screening follow-up program. And it kind of depends what kind of abnormal screen we're looking at. There are two different categories of those. So we have our early, our unsatisfactory, or our borderline positive screens. And early screens means that it was collected before the recommended 24 hours. An unsatisfactory screen means that the provider who collected the specimen did not collect it in a way that allowed us to run all of the tests. And then our borderline positive screens are results where it's looking like it's trending towards being abnormal, but we need some confirmation of that. In those situations, we do send a report out to the primary care physician who is going to be caring for the infant or their medical home and a request that a second sample be collected so that we can further explore what those results are. And that kind of triggers the whole system to start over. For our strong positive screens, we want to waste absolutely no time getting these kiddos into treatment, especially because many of the disorders that we're screening for are time critical. So we have contracted medical management coordinating centers specific to our diseases or category of diseases across the state. So we have contracts with Children's Hospital of Michigan, the Michigan Medicine, Spectrum, and it really is specific to the category of the disorder. But on a strong positive screen, we notify our medical management coordinating center for that condition, and they contact the family and bring them in for diagnostic testing. And so for a strong positive screen, we do not request a repeat because it's really time critical for us to get those kiddos in for that diagnostic confirmation of disorder. So newborn screening here in Michigan actually started in 1965 with just PKU. Oftentimes you'll hear this referred to as the PKU screen instead of a newborn screen. We're really trying to get away from that language because we detect far more than PKU now. But I just thought it would be interesting to kind of show you how this program's expanded over the years. And so in the beginning, from 1965 into the 90s, we were screening for, somewhere in the 10 to 15 disorder range. But between 2005 and 2009, we were able to add more than 40 conditions almost immediately as a result of the introduction of mass spectrometry into newborn screening. So that really allowed us for rapid expansion. And then since then, we've added a few disorders over time. We're up to 56 at this moment. Our most recent add this year was GAMT deficiency. And so the way that these disorders are added to our panel is we rely on a national committee called the ACT-DNC, who reviews and makes recommendations to a recommended uniform screening panel. Newborn screening is actually not run at a federal level, it's state to state, so not all states are screening for the same condition. So here in Michigan, we do our best to stay aligned with our RUSP, which is that national recommendation. So they review nomination packets that are submitted to determine which conditions are a good fit for newborn screening based on the availability of a test, as well as ethical concerns, availability of treatment, and many other factors that go into deciding whether or not a condition is a good fit. To give you guys kind of an idea of what is the reach of this program here in Michigan, in 2021, almost 103,000 newborns were screened through our newborn screening program. We had 302 that were diagnosed with one of the disorders on our panel. That put us at a detection rate for newborn screening disorders at 1 out of every 341 newborns screened. Since screening started in 65, more than 6,500 infants have been identified with a disorder through our program. We do keep annual reports up on our website at michigan.gov/newborn screening. And those annual reports have much more detail about the number of specimens collected, which disorders we're testing for at that time, which conditions were most commonly diagnosed, etc. So if you're interested in knowing kind of what conditions are included and how many kiddos in Michigan are being diagnosed with those disorders, both annually and cumulatively since 1965, that information is available through those annual reports. Okay, so we're going to shift now into what happens after newborn screening. And we often call our after newborn screening program the BioTrust, and that stands for the Michigan BioTrust for Health. So, are there blood spots that are left over after this testing is done? There are 5 to 6 blood spots that are collected from each kiddo here in Michigan to ensure that all lab tests can be completed. The amount of blood that is collected on the screen is determined by our newborn screening laboratory based on what they feel they need to run all of the tests currently included on the panel, plus a little extra to make sure that if they need to go back and repeat a result, or if some of the circles are not collected properly, that they still have enough specimen that they can maximize the amount of tests that can be run while minimizing the number of kiddos in Michigan who need to have a second screen collected. There is no additional blood that is collected specifically for research use. According to our MDHHS policies, we are able to store blood spots for up to 100 years, but our current retention practice states that blood spots will be destroyed after 35 years. So our effective retention time in Michigan is 35 years. So I put a little kind of graphic. We usually use this for families. It's not a realistic image. This is not real blood spots, but this is just kind of an overview of what the card can look like after testing's been done. So usually there are a few punches taken out of each of these circles. Sometimes there are circles that have no punches taken out. Regardless of what that looks like, all remaining blood spots or parts of blood spots are sent to the Michigan Neonatal Biobank for long-term storage. So a little background on why we have these samples. The basis of our retention actually dates back to the 80s. In the 1980s, the Michigan Attorney General gave MDHHS a ruling that they should retain residual newborn screening blood spots for 21 and a half years. This really wasn't based in science. It was more of a legal argument in order to protect the newborn screening program. They felt that we should keep the samples until the child who was tested reached the age of majority plus 3.5 years, essentially to provide kiddos with an opportunity to, I guess, in some ways, question the result of the screen. So if somebody ended up, being positive for one of the disorders that was on our panel at the time they were screened, they would have a certain time period that they would be able to come back to us and say, hey, I think you missed this. So in order for us to be able to confirm that all testing was done correctly, they did recommend that we keep them for 21 and a half years. In 1999, then Governor Engler hosted the Governor's Genetic Privacy Commission, and they also reviewed the storage of residual blood spots from newborn screening as part of that commission's mission. And I pulled here exactly from the report what they found, but essentially they recommended that because of these blood spots' present and potential value, that they recommended that these newborn screening samples be retained indefinitely since they represent such a vital resource for the study and treatment of disease. Following the Genetic Privacy Commission, our public health code was actually amended to allow research on these residual samples to occur. So I pulled out that portion here, and the bolded part you'll see says allow the blood specimens to be used for medical research during the retention period, as long as it's conducted in a manner to preserve the confidentiality of the subjects and is consistent to protect human subjects from all research risks. So now that we have these blood spots, how can they be used? There's kind of 3 categories of uses. And so the first use is they can be used by our newborn screening lab for quality assurance, test improvement, and test development. And this is probably the most critical use from the MDHHS perspective. These blood spots are essential in making sure that our current newborn screening system is working optimally. As we get new machines, that we can go back and make sure that we can replicate results on previous screens. And also, as we're adding disorders to our panel, they're critical in making sure that that test is picking up kiddos in Michigan. The second use is they can be used by families. So families can actually contact the department and request access to these specimens. Families have used these for genetic testing. They've been used to diagnose an untimely death. More commonly, they've been being used for for diagnosis of a congenital CMV infection. That's one of our more recent uses. There also can be used if families sign up for research projects, they can use this process to send a blood spot to researchers as well. And then the third use, and what we're going to focus on for the rest of my presentation, is they can be used for de-identified medical and public health research through our BioTrust program. So the BioTrust is an MDHHS program. It was actually created in 2009, and it oversees the research use of blood spots that are left over after newborn screening. Prior to 2009, blood spots were used in research projects, but in 2009, MDHHS felt that it was kind of time to put together a program that could oversee these uses, come up with ways to make these blood spots more useful for research projects, to store them in ways that better preserve the samples, and to use them in a way that's generally acceptable to Michiganders and that would allow us to inform the public and implement, when possible, opportunities for personal decision making in the research use of specimens. The BioTrust was really launched because there was a lot of increasing national and international interest in research using blood spots, and it became more clear that at the state level, we needed a process to ensure that there was oversight. There was advances in technology making blood spots more useful than they had been in the past, and we really wanted to create a more transparent process for the parents and the public. And finally, we wanted to invest in a storage facility that was equipped to optimally preserve our growing archive for many, many years to come. This is our organizational structure for the BioTrust. So it kind of starts here on the left-hand side with the Michigan Department of Health and Human Services box here in blue. We sit within the newborn screening lab and follow-up sections. We are responsible for public education about the BioTrust, and MDHHS is the entity that holds the key to blood spot codes. And that'll make a little bit more sense when we talk about our collaboration here on the right-hand side. The BioTrust is considered a medical research project, and we do maintain an active IRB review here at MDHHS. We contract our storage of blood spots out to the Michigan Neonatal Biobank, which is actually located at Wayne State University, and I have a slide on that later. They have a board of directors. It's made up of different research institutions around the state of Michigan who kind of come together to guide how these blood spots are stored and ultimately, ways that we can increase their use for research projects here in our state. On the MDHHS side, we have two advisory boards that oversee our use of blood spots. We have our Community Values Advisory Board that's made up of members of the general public, historical and cultural groups, health professionals, disease advocacy groups, and they're really responsible for making sure that the voice of Michiganders is heard when we're developing policies about the appropriate use of blood spots. So they help us create our policies about the way these blood spots can be used in research, and kind of as technologies change and science is advanced, they kind of help us consider if there are things that we need to do in order to further protect privacy of our Michiganders whose blood spots are included in the archive. And then we also have our scientific advisory board. Our scientific advisory board is made up of scientists around the state. And we have a panel of 3 members of the SAB who review each and every research project that's going to utilize blood spots. And we'll provide more detail about that process later. But their role is really to make sure that the actual projects using these blood spots are sound science and have the ability to accomplish their aims given the resources available in the archive. So our Michigan Neonatal Biobank. So as I said, the biobank's actually located at Wayne State University. It's in the Techtown Center of Excellence. They are a contracted storage and management facility for all residual dried blood spots here in the state of Michigan. They are a nonprofit, and they are responsible for our increased privacy and security protections, as well as improving our temperature and humidity controlled areas for blood spots. So I included a few pictures here on the right, just so you can get an idea of what the facility looks like there. I would encourage you. Chris Kraus is the manager. I don't think he could join us today, but I'd be happy to share his contact information if you're ever interested in kind of seeing what this looks like. It's right in your area. They are the facility that stores all blood spots left over after screening here in Michigan. And so you can kind of see there's a box and you can actually see those are what the cards actually look like after they've been punched as well. So after newborn screening is done, blood spots are labeled only with a code. and they are sent to the biobank for storage. Biobank does not receive any identifying information on these blood spots. MDHHS is the only group who can link that code back to the identifying information about the person that the blood was originally collected from. So, I'm not taking any responsibility for this because I was not here when the projects were named, but there is often a fair amount of confusion about the difference between the BioTrust program at MDHHS and the biobank, our storage facility. And some of that comes from their very similar name. So I just wanted to provide kind of just some clear, concise differences between the two. So the BioTrust is the MDHHS program that oversees the research use of these specimens. Our activities include outreach, community engagement, policy development, and then we do all of the coordination and approval of research studies that are requesting blood spots. MDHHS actually maintains qualified ownership over all blood spots while in storage. The biobank is our storage repository for blood spots. So they're responsible for storing and optimally preserving our blood spots, and we do contract with Wayne State University for this service. However, the biobank only releases blood spots to MDHHS approved researchers when they are directed to do so by the BioTrust. So this will make a little bit more sense when we talk about the process for accessing specimens and what the biobank's role is in that. So as mentioned, the biobank was really responsible for improving the storage conditions of blood spots. And so I won't go into the nitty-gritty details, but this is something that most researchers find helpful when they are considering using this archive for their own purposes. We didn't start our contract with the biobank until 2009 when our BioTrust program formalized. So prior to that, blood spots were stored in our MDHHS lab retention center in really uncontrolled temperature and humidity environments. There are still some specimens that are in storage here in Lansing. That is some of our older specimens that were already there before we started our contract, and work is always ongoing by our lab to process those out. I think we have about 3 or 4 years of specimens that are still in storage here at MDHHS that we are working to move over to the biobank archive. Once we get through to closer to January in 2009, that's when we started sending blood spots to the biobank shortly after testing was done. And that was something that we continued to work on improving through October of 2010. So since October of 2010, specimens were frozen within 14 days of collection and are stored at the MMB repository. Now, for our older spots that were already stored in uncontrolled temperature and humidity environments, when those are transferred over to the biobank, those are actually stored in a non-frozen space at 70 degrees and 35% humidity. And that was a decision that we worked with our scientific advisory board to come to an agreement on, since they had already sat for a long period of time unfrozen. And then there's a few notes here on the right-hand side that we did have some time periods that had undergone freeze-thaw cycles as well. So what's our archive look like? So currently our archive dates back to 1987. So we have blood spots in storage since 1987. More than 4 million blood spots are currently included in the archive. And annually, there's over 100,000 specimens that are collected for the purpose of newborn screening that are eventually added to this archive. Of the 4 million blood spots that we have, 3.5 million of those have been processed, inventoried, and transferred over to our biobank storage repository. So, I'm sure all of you already know a lot of this information, but why are these, such a unique resource for research? Research has shown that these blood spots can be used to measure more than 160 biomarkers, things like proteins, genetic materials of both human and viral and bacterial strains. They can also be used to measure metals, other environmental toxins. Really, if you go into the literature, they have been used to measure so many different items, and so they've really become a resource that has gone for a long time underutilized. These blood spots provide a snapshot of biological function shortly after birth. Most of our blood spots are collected between 24 hours and 36 hours after birth. So that's kind of the time window we shoot for in newborn screening. So you're looking at a specimen collected from an infant very shortly after birth, which is really hard to do for research purposes, to convince a family to sign up for a project that involves an extra poke, about a day after a baby is born is sometimes difficult to accomplish. And these blood spots do accomplish that aim. These blood spots are no longer needed for clinical purposes, so they are available for research. They have the potential to reduce disease burden in both children and adults. We've had researchers who have looked at, childhood cancers as well as adult-based cancers based on our 35-year retention schedule. And they do represent opportunities to conduct population-based research just because they are collected on all Michiganders. I'm going to put a little caveat on that because we're going to have a later slide that talks a little bit about our consent process for specimens collected after 2010. But it is possible to do. And they also represent a really unique opportunity to link up biological samples to data that's routinely collected by state registries. So we're able to link these blood spots to data sets at MDHHS, and I'll include some information later about which registries we've been able to do so far. When we think about what kind of research can be done with these, it was really important to the department that we make sure these blood spots are being used in a way that is kind of generally acceptable to our Michiganders. So I mentioned our Community Values Advisory Board. They are critical in formulating our MDHHS policies about blood spot research. All projects must comply with our policies, and they must go through our BioTrust application process before they can access blood spots. All research must be related to studying diseases or improving the public's health. There are also some key categories of things research cannot be done on. They're quite obvious and broad categories, but cosmetic research, chemical, nuclear, biological warfare research, or other non-health related ventures. Researchers cannot access identified blood spots or perform whole genome or whole exome sequencing unless they ask each individual for specific consent to do so. So we're going to go through what our consent options for families are here in just a few slides, but I don't want to say you can't do those things because you can. If you're interested in accessing identified blood spots or performing whole genome or whole exome sequencing, it is possible, but you would actually have to recruit those subjects yourself and have them sign an informed consent document that indicates they're comfortable with those uses. And we do have these policies up on our website, so I have included a link here if you would like to read through those. Since 2010, there have been 77 research projects that have been approved to use blood spots from our Michigan archive. So you can see here kind of the breakdown by year. In 2013, there was some funding from BLEEP that was specific to blood spot use, so there was kind of a boom there. But consistently, we're usually somewhere in the 5 to 6 project range of getting these projects approved per year. Thought it might be helpful if I shared just the titles of projects that were approved in 2022, so you can get an idea of what researchers have recently been approved to utilize these specimens for. So I'll just let you read through those. And really what I want to note on this slide is our BioTrust online research report. So we keep a list online on our website of each and every project that has been approved to use blood spots. We really do this so that Michiganders and the general public can have a sense of how these specimens are being used. It's really important when families are thinking about the BioTrust program. They often want to know, okay, you're saying medical and public health research. What does that mean in practice? How are they being used? So this includes information on the title of the project, a brief abstract, the institution where it's happening, how many blood spots are going to be involved. And then as projects wrap up, we actually ask researchers to provide just a few sentences of an overview of what the findings were and links to any publications. So I bring it up for you guys today because if you're wondering, hey, I have this idea, has anything like this been done with blood spots? Or hey, I want to measure this protein, has anything like that been done here in the state of Michigan? You can search this research report and see kind of exactly how researchers in our state have used these specimens. Okay, so I talked a little bit about, making sure there were ways to implement personal decision making for our Michigan families. So Michigan was actually the first state back in May of 2010 to implement what we call a statewide prospective consent process for the research use of blood spots. This consent form is actually physically attached to the newborn screening card. So families get this form when their child has blood spots collected for newborn screening purposes in the hospital or in the home birth setting. So this form allows parents to decide if their child's leftover blood spots can be used in research. And again, it's executed by our birthing attendants in both the hospital and home birth setting. This is not a consent for storage, so all blood spots are stored for up to 100 years unless parents sorry, it is up to 100 years with the current time at 35. But parents can contact us and request that these be destroyed. It's pretty rare. We receive about 40 requests total per year for families who want blood spots destroyed. So just to give you an idea of what our consent numbers look like in Michigan, we have a yes consent form on file for about 60% of all specimens that have been collected since May of 2010. So that's more than 800,000 parents who have consented to allow their child's specimens to be used in BioTrust research projects. However, when I put that caveat on population-based research, this does have implications on random sampling techniques. And we can share more information, but just briefly, we are less likely to have a yes consent on file for non-white subjects. We're less likely to have a consent on file if the child was in the NICU setting, and we are more likely to have a consent on file for older mothers and mothers with higher levels of education as well. So those are some known and documented differences between the pool of people who have consented yes and those who either have said no or we don't have a consent form back on. There's about 13% of samples in the last quarter where we just didn't get a consent form back at all. So in those situations, they're automatically marked as not available for research. So they're only available if the family had a documented yes consent on file. And if you're interested in knowing more kind of specifically of what the strength of those associations are, we do have a presentation and a poster available that we presented at MSU's EPI conference a couple of years ago that we would be happy to share. Okay, so blood spot availability. So the availability of blood spots for de-identified research does depend on the date that the sample was collected. So I'm actually going to go to the bottom of this table. If the sample was collected after May of 2010, the blood spot is only available for use in de-identified studies if a yes consent is on file with MDHHS. For older samples or samples that were collected between 1987 and April of 2010, all of these blood spots are actually available for research. They are available under a waiver of informed consent that is granted by the MDHHS IRB. They review that waiver annually. So before April of 2010, the vast majority of blood spots are available. The only time that a blood spot would not be available for a de-identified study is if a family has contacted us to opt out of that. But that is a pretty rare occurrence. And then after May of 2010, it's only available for use if that yes consent is on file. I also wanted to talk about identified projects or projects that want to do whole genome or whole exome sequencing. So again, if researchers are requesting identified information or doing that sequencing, a study-specific informed consent must be sought by the research team. Per our MDHHS policy, it does have to include a written signature on the document. By written, we do mean an in-person signature or an electronic signature is acceptable, but there cannot be a kind of a broad waiver of signature requirement on these documents. Even if you were interested in doing a study-specific consent project, that project will still need to undergo our BioTrust research application, and the IRB will need, our MDHHS IRB will need to review that study-specific consent document before it's used. And then following the approval of the project through our application process, the researchers would provide the copy of the informed consent document for each subject to MDHHS, just so we confirm that that person did consent to the release of an identified blood spot. I talked a little bit about data sources that are available for linkage to these blood spots. So I just thought I'd highlight some of the databases that we've linked to most recently. We have linked these blood spots, of course, to our newborn screening records. They're already linked, so that's very easy. Our newborn screening records include information from the screen, including results and analyte values for any of the conditions that we test. And we do have a data dictionary that lists all of the different analytes that are measured on a newborn screen. We've linked them to our Michigan Cancer Surveillance Program. So we are actually able to identify blood spots from persons diagnosed with specific cancers, as well as access data that is collected through the Cancer Surveillance Program as well. We've linked to the Michigan Birth Defects Registry. We've linked up to Medicaid records, and we also routinely link to vital records such as birth and death certificates. So if you're planning a research project, it is possible that you can get both blood spots and data elements from MDHHS as part of that project. However, if you are going to request any data elements be connected to a blood spot, we do have some additional what we call uniqueness testing guidelines. This is something that was developed to kind of provide further protection for research subjects whose spot is being used. So this is very specific to if you're using blood spots with data. If you are performing just a data only project and not accessing blood spots, these guidelines would not apply. But essentially, the profile of sensitive data elements for each participant included in your project must match at least 5 other eligible subjects. So if you are getting, race, sex at birth, diagnostic information about somebody and it's de-identified, we take these sensitive data elements and just make sure that it matches at least 5 other people. This is especially important to us when we have research on rare diseases, just because some of our newborn screening conditions, there's 1 or 2 kiddos in a given year, maybe not even 1 kid a year. So giving out information about that diagnosis, it's just extra important to us when we are releasing blood spots that we have some additional layers of protection. Now, if the profile does not match at least 5 other eligible subjects, we don't throw the data out. Our epidemiologist would actually work with the research team to come up with different categorical options that would make those categories wider. But it's very much a collaborative process between MDHHS and the research team, and we do our very best to implement these guidelines without, compromising the data itself. I wanted to highlight that we do have, this is really new, it's actually going to be up on our website. I was hoping it was going to be up and online already today, but it doesn't look like the new web page refresh has hit yet. So it's coming very, very, very soon. We created kind of a BioTrust research manual, and it's everything a researcher would need to know about using blood spots here in the state of Michigan, really in detail about what blood spots are available, what type of research can be done, and the process for applying. So if you're interested in using blood spots, or if you have, other persons in your lab who may be interested, we would encourage you to share this information with them and let them know that this is available. It's a very helpful document. And I'm going to go through much of what's included here in the next couple of slides. So how do you actually request blood spots from Michigan? So I mentioned that we have an application process. So research applications do have to be submitted to the BioTrust, and they undergo a multi-step review process. It starts with just an initial review of the application by myself. So I review all applications, make sure that they're complete, they're feasible, and that they generally comply with BioTrust policies. After that, the project is submitted to the MDHHS Institutional Review Board. So it's just an IRB review. We do not participate in reliance agreements for projects that are requesting blood spots. In addition to IRB review, our BioTrust Scientific Advisory Board reviews each and every project as well, and they ensure that each research use has scientific merit and, again, complies with our BioTrust research policies. So it's really a 2-tiered review system. There's an IRB review and an SAB review. Now, the information submitted to both is the same. So, you aren't preparing 2 different applications for review, and I'll go through what is included in an application later. After the IRB and the SAB have approved the project, there are a few agreements that would need to be executed before blood spots or data could be sent out. If you are requesting data, we would do a data use agreement. And for all projects, since you would be getting blood spots, there will be a material transfer agreement that is executed between MDHHS and the testing lab itself. So an application generally includes our MDHHS IRB form. We have a BioTrust request for samples form. This is a form kind of specific to blood spots that we've put together for this purpose. I think it's about 3 pages long. We also request a detailed and comprehensive study protocol, and then we also request copies of the principal investigator's CV and proof of human subjects training for the principal investigator as well. So as soon as that new page goes live, the forms that you'll actually need to apply to access blood spots will also be there. But in the meantime, if you're interested in getting these forms, you can email me. You can use this biotrust@michigan.gov, or you can use my personal email address. Either way, they both come to me. Once the documents are prepared, the application materials are submitted by email to myself. What do the timelines like this look like? Our IRB, they generally estimate that their review will take about 4 to 6 weeks. They convene the first Tuesday of each month, so application materials have to be submitted to the BioTrust 15 business days in advance of the next meeting to ensure review at that meeting. Not all projects do go to like full committee review by the IRB. So even if you don't hit that deadline, there is a chance that the IRB will review that separately. But as a general rule of thumb, we do prefer that if you want to be reviewed or guarantee review within at that next monthly meeting, that the application come to us 15 business days in advance. For our SAB review, we also estimate that takes about 4 to 6 weeks. When possible, we try to run this concurrent to IRB review, so IRB and SAB would be reviewing at the same time. That's always ideal. We do not always achieve that. It really just depends on the number of projects that were already submitted when we receive your application, or it depends just on the availability of our SAB reviewers to participate in a panel. But we do our best to kind of keep this process as short as we can. However, we don't always achieve concurrent review there. For our agreements, the final execution of a material transfer agreement, that takes about 5 to 10 business days here at MDHHS. That does not include any review time by your institution or any back and forth on if there are changes that are needed to the terms. But on our side, once it's signed by the university or whoever is performing the research project, it takes us about 5 to 10 business days to execute that. And then for our data use agreements, if you are getting data, we would have to do this agreement. Our MDHHS compliance actually has to review DUAs before any signatures are sought. So essentially we fill out the form based on what information you'd be getting. The MDHHS compliance office reviews that. They would then release it for signatures. We would send it to your institution for signing, have any back and forth that's needed. And then once we have it back, again, that final execution here at MDHHS takes about 5 to 10 business days. Once an application has been approved and all the agreements are executed, our newborn screening epidemiologist will then start selection of blood spots based on the project criteria. If any additional MDHHS data is needed from other registries, we would coordinate retrieval of that information. You don't have to do that. We would work with the other MDHHS programs involved to get all the information that we need to complete the blood spot selection. Once selection of blood spots is complete, we actually send a list of blood spot codes that should be included in the project over to the Michigan Neonatal Biobank. And we let them know that they are approved to release that set of blood spots to the research team. The biobank would then prep samples and coordinate shipment with you. So for most of the application process, you're working directly with me at MDHHS. Once that's done and we've selected the blood spots, that kind of shifts over where you'll be working with the biobank staff on the physical shipment of blood spots. The timeline for that, it's hard to estimate because it does depend on the size and complexity of the request. It also depends on if we have other projects in the queue at the time that request comes through as well. But for the most part, I would say our epidemiologist takes about 4 weeks would be kind of a good estimate for what it would take for her to fit that into her schedule. There are costs associated with using blood spots in research. There are 2 separate costs that all projects would have to pay, and these are assessed separately. There's one that is the BioTrust program here at MDHHS, and then the second comes directly from the Michigan Neonatal Biobank. So I included a little bit of information. There is a full cost recovery structure included in that BioTrust research manual, or I can email that out to you as well if you're interested for the MDHHS side. But here at MDHHS, our cost recovery fee is assessed at $75 an hour to cover MDHHS staff time involved in project approval and sample selection. We will provide quotes once we get your application has been submitted, or if you have just kind of a general idea of what you're planning to do, we work with you to get you quotes just so you could know what might be needed. We do not require payment until specimens are received, you're on your way with the project, and kind of the project is complete is when we would bill our MDHHS stuff out. Now, I will note that if you use MDHHS data outside of newborn screening, there could be additional fees. So I know our vital records team and our cancer surveillance team, they have their own systems for recovering their staff time involved in these kinds of projects as well. The biobank, their fee starts at $10 for a 3 millimeter punch. It is not payment for a blood spot, rather it's an estimate of what it costs them to ship and prep each sample. So they will also provide quotes by emailing. All you would need for a quote from them is the number of total samples that you'd like to receive and the size of the punch that you would want. So a 3 mm punch is kind of what we generally use in newborn screening. So we're often working in 3 mm punches, but there is an option to get a 6 mm punch, and a full blood spot is about 12 millimeters, and we can provide you more information on area equivalents and things like that if you're interested in kind of figuring out how much blood you might need for your assay. Unlike us who don't require payment until the project is done, Biobank does require payment prior to shipping out specimens. So you will not be able to get the specimens until you have paid their fee. That process is usually fairly simple. And what they do is they have their billing folks work with you on that payment part while they're working on prepping the samples so that they can cut down on any time delays for that as well. Okay, and that was my last slide. I would be happy to take any questions. I know we have about 10 minutes left.
I had just a comment. I wanted to say this is how we did our pilot project for the SCID newborn screening about 18 years ago. It was back in the day when Dr. Young was there, and your repository of samples was still in Lansing, and we had to go into a garage and pull them separately. But, you know, even with all that, we were able to demonstrate that the TREC assay worked. We were able to demonstrate low T cells in several children from the previous years, and we were able to get it on the newborn screening. So this is a very viable way and a great resource that we have in Michigan. So thank you.
Yeah, thank you for your kind words. That's really nice. Yeah, we've definitely invested a fair amount of time and resources in making these blood spots even more usable. So, you know, I think, again, if you're interested in knowing what people have already done with them, things like the SCID project, that research report online has that. There's also, you know, a lot of papers about researchers who have used our older specimens even, and knowing, you know, the feasibility of using those specimens for genetic assays and things like that on there as well. So thank you so much. And I hope now that if you were to use them again, it would maybe even be a little bit smoother for you.
Thank you. I've got to sign off, but thanks again.
Hi, Shelby. I have a question. First, a comment, I guess, is that I have a little bit of experience analyzing blood spots along with Dr. Bina Sood in a project where we were looking at microRNAs. And I was actually amazed at the quality of the data that we obtained. But now I'm wondering, has anybody ever looked at or reported any differences in quality of results when using the older blood spots that were stored at room temperature versus the newer spots that are now stored, you know, at -20?
Yeah, so Dr. Philip Luvo, who is a cancer researcher out of Baylor, he actually has a whole paper, and I'd be happy to send this around if anyone's interested. He had a postdoc who actually did kind of use that as a mini project of looking at our older specimens versus our frozen specimens. And he actually came and presented to our advisory boards. They got very good data from those older specimens. They needed a little bit more specimen, and they did, I think, use a different kit. They used a different assay for the older specimens and the frozen. But yeah, there actually is a published paper kind of specifically looking at that. They were doing they wanted to know the feasibility of doing some genotyping work on those older samples. So yes, that paper does exist. It is linked on our research report, but so you don't have to search if you're interested in seeing that. I'd be happy to send that to you.
Great, thanks. Graham, I see you have a question.
Actually, it was firstly a comment to thank Shelby for a great presentation. It's very clear. It's nice to know that you're going to be updating some information online.
Yes.
Our researchers to be able to access. You're probably aware I work with Cures. I work with Doug Rudin and other people who have made very, very good use of your resources before. And I just wanted to really encourage my colleagues when you're thinking of a research question, you're sometimes a little hamstrung by what your time scale is. You can only do slice work, if you like, in terms of looking at samples and getting results. But really what you have here is a time machine. You can be asking questions about samples you're collecting now that there's data that already exists. And especially if you've got a student or a fellow or someone working with you that's got a very limited timescale, you can actually ask some very complicated and interesting questions that allow a much more even literally transgenerational research project in a relatively short time.
Yeah, I worked closely with Doug when I was at MSU. He was part of our ECHO team working on our March project, our prenatal outcomes project across the state. And now Doug's actually on our scientific advisory board. He reviews projects for us, and he actively receives specimens through the ECHO grant as well. So we love working with Doug.
I just have a question about the fact that the original newborn screen is billed to the insurance companies.
Yep.
And I'm just curious about, do you have to involve them or get their consent, to use the leftover blood spots for research, just out of curiosity?
So the way that we do this at the state is actually the hospitals themselves purchase the cards in packs, and then they reimburse themselves through insurance. So for the most part, hospitals kind of build that cost into, I can't remember, there is a name for the charge, but there's kind of like a general charge for hospital time invested in a delivery. So they actually bill it out to insurance. So it's fairly rare that the insurance actually sees like a line item for newborn screening. So for our purposes, we don't have any interaction with the actual insurance companies who are paying them. We do sometimes have interactions with families, specifically for those who deliver in the home setting. So if you have a home birth, you actually have to pay for the screen yourself, and then you can seek a reimbursement from your insurance, but we don't do any billing to insurance. We do offer kind of a fee waived process as well for families. So if they're eligible for Medicaid, they don't have to pay for the screen, just because we never want a child to not receive screening because insurance isn't available and the family can't pay. But actually, yeah, the hospitals purchase the cards directly from us in packs, and then they bill it out to insurance through like a general fee for the most part. So our involvement with the insurance agencies who actually end up covering the cost is low. So the hospital kind of has to front the cost for that and seek the reimbursement from insurance.
Hello, Shelby, can you hear me?
Yes.
Hi, it's Martin Toby. It's absolutely fascinating. Thank you so much. So I have often wondered, I work with biomarkers and currently interested in dementia. And what you have is very valuable data, I believe. I don't know how stable the proteomics are compared to the genomics, as you previously discussed.
Mm-hmm.
But we do have the National Institute of Neonatology here in Detroit. They have a lot of stool samples, and that's one of my interests. If we could meld what you have in terms of proteomics and together with the stool samples, we could probably have a biomarker that might tell us which people are at risk of developing dementia and possibly reversing it, because now there are drugs coming through which can only be used at an early stage. But this would be a tremendous resource, because I don't know a single family that has not been touched by this terrible disease. Now, also, if you could put up your number again, you flashed it up. All I got there was 517.
Oh, yes. I'll throw it in the chat so you can have it. I'll put my email address in my chat in the email, my personal email. Yeah, so we have had projects that have linked to either clinical, I think for the most part, we've done clinical data. But it is certainly feasible. There would be a couple different options to kind of connect blood spots to that. What I'm thinking now is, of course, you could recruit subjects who have that if you don't have the identified information. We have done in the past, specifically it was a cancer project where the researcher, we selected cases based on the cancer registry, and then we sent that information to facilities who actually reported the cancer to the registry, and they pulled some additional data for the research team as well. So we might have to get a little bit creative, but it is definitely feasible and something that if you're interested in, please contact me, because we can work through kind of what might be possible for those situations to try to link those up. It is definitely something that we would be interested in working with you on.
Great, thank you so much.
Any other questions?
Thank you.
Well, Shelby, I'd like to say thank you very much for a great overview of a fabulous research resource, underutilized, and hopefully we can move forward with some new projects through your group and utilizing these blood spots. So thank you very much, and hopefully we'll be in contact down the road with some questions and some applications for use of your blood spots.
That sounds good, and I'll follow up with some information for Dr. Domkowski, and then once that research manual is live, I can send a little ping with the link, and you'd be welcome to share that with anybody who came, just so you guys can see that information online. And of course, please feel free to share my slides in the recording.
Great. Thank you very much. Here's a round of virtual applause for Shelby. Thank you.